getting even much worse with the with the previous technique, and now with the malleus replacement prosthesis, it's getting even better. And this is my personal experience that I have now with time. I may need to publish a new series. And these are the total cases I made since 2009, because I introduced this prosthesis in 2009, the malleus replacement prosthesis. And I was using a simultaneous prosthesis at the beginning of mainly TORPs, but also sometimes total piston and sometimes a PORP. And I was also using it in some revision otosclerosis case. So you can see again the situation. And in terms of results, this is what I had if I had the group D. 76 cases. This is the success rate. In the group C, with malleus replacement prosthesis plus silastic band, you can see the success rate, which is pretty good. And in group F, not as good because of the pathology itself, of course, as we all know. Just to finish, because many people have asked me the contact that we have for the COS clinic. You have access to the YouTube channel. Most of you have been there to see the different techniques that I'm using. So if you just take a picture of that, you have a QR code, and then you go directly to this, and then you have access to all the techniques we are using. But if you want to spend some time at the clinic, so this is why I just add this for you, you have two emails that you can use. Contact cliniccos.com and ML Bodenau, who is my secretary, cliniccos.com. It's better to send me email before, so we check the possibility in terms of schedule. And I have one advice to give you. If you want to apply for, this is not connected to pathology or medicine. If you want to apply for a visa, apply for a tourist visa and not any other, because the French administration is getting really terrible, and if you apply for any other type, you will be in trouble to get that. So tourist is fine, okay? So just send an email and we'll reply. Thanks very much for your audience.
Thank you very much, sir, for your fantastic talk and high definition videos, precision surgery, and I'm sure all the results are excellent, such beautiful techniques, like silastic band and others. If you have any questions, we have 2 more minutes.
Yeah.
Any questions? I think you're crystal clear in your concept. Thank you very much.
They are fed up with the French now.
Thank you, Doctor. I request Dr. Bashir, Professor of ENT, MES Medical College, to handle the clinical chairperson. Doctor. For our next talk by Dr. we would like to invite our chairpersons, Dr. Murali, Head of the Department, GNM Hospital and Research Center, Mumbai, and Dr. Sunita Chapola, Senior ENT Surgeon, Mumbai Coal Trust Hospital.
Good evening. First of all, I am myself, along with my co-chair, thank the organizers for honoring us to chair this session. And Dr. Murali has been introduced just 2 lectures before. He is a famous neurosurgeon from Netherlands, and he had done a lot of papers on researches of tinnitus. He had done a lot of work on phantom pains also. And he has many publications. I was going through the Google and I could see a lot of publications, chapters in textbooks of neurosurgery on his behalf. Welcome. I again welcome Dr. Rader to deliver his lecture.
Thank you very much.
Thank you, sir.
So, I will now, instead of talking about pulsatile tinnitus, talk about non-pulsatile tinnitus, which is, of course, the majority of patients that you see in the clinic. And why is that? Well, because 15% of the population is afflicted with non-pulsatile tinnitus, and it rises with age. It's somewhat more present in males than in females, somewhat more in the left and the right ear, and more in people with hearing loss than in people without hearing loss. Now, 80% of the people with tinnitus have no problem with it. They can live with it. But 20% of the people with tinnitus are severely affected by their tinnitus. And it is in the American and US Army, it's the most common problem for returning veterans. And therefore, all of a sudden, since a couple of years after the war in Iraq and Afghanistan, the American Army became interested in trying to understand how tinnitus works. Now, initially, it was very simple. Up to 2002, tinnitus was an ear problem, and that was it. But then there was the stories about, well, that's very simple. Let's just cut the auditory nerve, and it will be solved. But the problem was that when you cut the auditory nerve, in less than half of the patients, the tinnitus stays the same. And so then it was thought, well, it's still very simple. Instead of tinnitus being a problem of the ear, it's a problem of the auditory cortex. And if something goes wrong in the auditory cortex, you get tinnitus. But then we started implanting electrodes on the auditory cortex, and initially we only had 1 in 3 success rates, a very low success rate. So we had to come up with still another story. And then in 2009, based on work by Winnie Schlee and others, it was suggested that it's not just a problem of the auditory cortex, because we knew that if you present an auditory stimulus to a patient in vegetative state who clearly has no consciousness, the auditory cortex lights up, but the rest of is disconnected from the rest of the brain. So this auditory cortex activity needs to be linked to a network, which you can call a consciousness enabling network in the brain. And now we're actually looking at tinnitus as a problem of information processing, and we're currently analyzing entropy data, so a lack of information in the brain, to see whether that can explain the tinnitus. So there is an evolution in going from the ear to the auditory cortex to the entire brain, to how the brain processes this tinnitus information. Now, in our recent studies, and of course for otologists, that's very clear, but for neurosurgeons or neurologists who study the problem, that was not that clear from the beginning, because we thought there was a final common pathway where all kinds of tinnitus would ultimately create the same changes in the brain. But we found that when you have hearing loss, when you have no hearing loss or a hidden hearing loss, then the problem is actually not in the auditory cortex, but in the pre-general anterior cingulate, which is a starting point of the descending pathway that suppresses information. So if you have a deficiency of noise cancelling, then you can get hyperactivity, which is exactly the same what you feel in fibromyalgia patients in the pain domain, or what you feel for patients with vertigo. When you record their brain activity in between episodes of vertigo, they also have a deficiency of this part that runs in the pain system to the periaqueductal gray, but then the auditory system to the tactile longitudinal column, which is just behind the periaqueductal gray, and then probably just connects to your olivocochlear bundle. And then you've got a second group where tinnitus is associated with hearing loss, and where the lack of auditory input causes changes in auditory memory in a parahippocampal area that connects, and especially the connections between the auditory cortex and the parahippocampus. So the idea is that when you have no hearing loss, you've got a problem in the auditory cortex, but predominantly because of a lack of inhibition from frontal, and when you have hearing loss, that it's auditory memory that pulls, just like in phantom percept, pulls the tinnitus information from the brain. Now, treatments, you can find lots of these things on the internet, but unfortunately there is no miracle cures, and on average, whatever you try seems to work in 20 to 30% of the patients, which is about exactly what you would expect from a placebo to do, to work in 20 to 30% of the patients. Now, the way we manage tinnitus patients is we try to treat the cause if one is found. If not, you can do a TRT, which is basically a form of cognitive behavioral therapy, even though the inventor of it would strongly disagree if I say that. You can use hearing aids and noise generators. You can use medications, especially for patients who have associated symptoms such as distress or depression, or who have their tinnitus dominantly present for more than 60% of the day. If none of the more conservative treatments work, then you can try neuromodulation, and if that doesn't work, we enroll them in experimental studies. So we first look for a cause of non-pulsatile tinnitus, and if we find a cause, we will treat it. For example, a vestibular schwannoma, an arachnoid cyst with displacement of the nerve, Meniere's disease, a vascular compression, even a tumor that is close to the auditory cortex can cause tinnitus. So treat the cause if you can. If you do not find a cause, then you can go to symptomatic treatments, which, of course, the most successful treatment up to date for tinnitus is the cochlear implant, which is way better than we have been able to reach with any other treatment. But, of course, you can't put cochlear implants in every person who still has functional hearing. So what we routinely do is we start with non-surgical neuromodulation, transcranial magnetic stimulation, where you send pulses, magnetic pulses, through the skin, skull, a bone, and then you reach the auditory cortex or the frontal cortex or whatever cortex you want to reach. You can use stent stimulation, just electrical stimulation, which we predominantly use in the C2 area because the C2 area connects to the cochlear nuclei directly and also connects to the trigeminal nuclei. We use direct current stimulation. Direct current stimulation, you've got an anode and a cathode. Basically, it's a car battery where the current goes from one anode to one cathode. 50% goes through the skin, half goes through the brain, and depending on where you put the anode and the cathode, you can play with where the current is going. Now, you can also, instead of using direct current, you can use alternating current, so the current shifts, or random noise stimulation, which is a specialized form of alternating current. You can use neurofeedback, which we've used for tinnitus distress, where basically you record brain activity, you compare it to a healthy control group, and what is deviant, you try to normalize by giving a feedback, which could be a bar that goes up and down, could be a movie that stops or continues. ECT we've only extremely rarely used when there was a severely associated depression. Now, there is multiple parts of the brain that are involved in processing or generating tinnitus. As I mentioned, when a patient is unconscious and you present an auditory stimulus, the auditory cortex will light up. So this auditory cortex has to link to other parts of the brain in order to generate what you could call the unified perceptive tinnitus, which means the tinnitus is heard in, let's say, the left side, has a certain loudness, has a certain characteristic, could be noise-like, could be pure tone, is associated with, can be associated with distress, which is predominantly an autonomic sympathetic nervous system problem. It is linked to the memory networks. It is linked to attention networks in blue. So basically, there's lots of other parts of the brain that are involved, and you could theoretically try to modulate these different parts in order to, in an attempt, surgical attempt, to treat those areas. Of course, the most common, the easiest thing was just go to the auditory cortex, block it, and tinnitus will be cured. So the idea was initially very simple. Tinnitus is related to reorganization and hyperactivity of the auditory cortex, which you can show with an EEG, where if you look at power to frequency analysis, the normal 10 hertz bump that you see slows down to theta to 4 to 7 hertz, and the high frequencies are increased. So the normal blue activity normal blue activity at 10 Hertz is replaced by increased low frequency combined with increased high frequency activity. This high frequency activity actually correlates with the bald spot on fMRI, so you can use an fMRI as a target to implant the electrodes, and then you can use this target to first non-invasively stimulate the auditory cortex. If that gives a benefit in 2 placebo-controlled sessions, then you can go ahead and implant an electrode extradurally overlying the auditory cortex. And we started probably in 2004 and thought we would cure everybody. But unfortunately, already from the first 10 patients, we saw that was not the case. Because only patients with a pure tone had benefit from the implant on the auditory cortex. When you suffered from a noise-like tinnitus, nothing seemed to happen, which was a little problem, and that could be due to two reasons. One is because the electrode was wrongly positioned, or 2, because the current tonic stimulation that we were using was just not getting any modification of the narrow band noise. So what we did is we looked at fMRIs and fused them with the postoperative CT. So here you see an electrode extradurally and one in the Sylvian fissure overlying the bald spots when you fuse these two. So the electrode was correctly positioned, but there was no clinical benefit. Now, the brain uses 2 languages. It fires in tonic mode, which is what is mimicked by tonic stimulation, but it also fires in burst mode. And burst mode is a salience signal. It says this is important and is a non-specific signal, is non-tonotopically organized, whereas regular firing occurs in a tonotopically organized lemniscal system. This occurs in the non-tonotopically organized extralemniscal system. So the idea was, what if hyperactivity in a non-tonotopically organized system creates noise, and hyperactivity in a tonotopic system creates a pure tone at a specific frequency? Then, in order to try and treat all the frequencies, we should mimic this. So we had engineers build a stimulation design that we then applied to 5 patients with pure tone and narrow band noise. And for pure tones, just as our previous experiments had shown, there was no difference between tonic and bursts, because burst and tonic stimulation seemed to modify pure tones. Whereas for narrow band noise, tonic had no suppression, and with burst we could get 61% suppression. Still not good, but at least we could rescue some of the patients who were failures. And so if we look at the first 43 patients that we implanted with an auditory cortex electrode, and they were all put in tonic mode because that was the only stimulation design we had, actually only 1 in 3 was a responder. So we implanted 2 out of 3 patients for nothing. It was not worthwhile to continue, except if we could improve this. So then we introduced the burst stimulation based on the philosophy that burst is a non-topographic, non-tonotopic activator, and we could rescue about half of those non-responders, so creating 2 out of 3 responders, which is still not ideal, but it's better than 1 in 3. And when we switched the responders to burst, half of them also improved. So basically, at least part of the story was the communication with the brain in a language that it did not understand. So in order to further understand, well, how can we improve our results further, we looked at brain activity by comparing patients who did not respond to the implant to patients who did respond to the implant, and we expected to see a difference in the auditory cortex because we were still convinced that the auditory cortex is the problem. But no, actually the difference was in this medial area in the brain, which is called the hippocampus and the parahippocampus, which is where auditory memory is stored. So we said, oh, that's the problem. The problem is that patients with tinnitus pull the tinnitus from their memory, just like phantom limb patients do. But how can you explain it if you put the electrode here, that in some patients you can modify that, and in other patients you don't seem to modify that? So a way to do that is to look at functional connectivity, which basically measures the way different parts of the brain work together, which means there is a communication between the two. And what we could show in those series was that actually the ones who responded were the ones who had connections between the auditory cortex, where we put the electrode, and the parahippocampal area. So then it made sense. It was just that with the wrong model, we still had good results. A little bit like Thales of Mileto in 585 before Christ predicted a solar eclipse with the wrong geocentric metal, but even using the wrong metal, he made the right prediction. And so we did the same thing with the wrong idea. We had some successful results. So then we thought, well, how can we non-invasively study this part of the brain? How can we non-invasively, because it's deep, and it's, so one way was to do selective catheter, and so you introduce a catheter selectively into the anterior and choroidal artery, which supplies the hippocampus and parahippocampus. You inject amytal, and basically you put that part of the brain asleep for about 10 minutes, and then you just ask the patients, is your tinnitus improved or not? And when we did this in some patients, what we saw is that when the patients had tinnitus for less than 5 years, there was no improvement. When it was longer, there was some improvement, but again, predominantly for the pure tones, less so for the narrow band noise. So it seemed as if we could study this in a non-invasive way, and then we said, well, why don't we go a step further and just implant an electrode in that part of the brain that seems to be involved in tinnitus. So the first patient, he responded to this amytal test, where we basically put that part of the brain asleep for 10 minutes, and we did an fMRI study where we presented the 8,000 hertz tone that he was hearing, and then basically targeted the area within the bald spot. And here you see the entry of where the electrode was. This is the trajectory of the electrode, so coming from the back of the head, going anteriorly to that part. And in the first week, the tinnitus was unchanged, but it was not annoying anymore, which probably was due to the fact that the tip of the electrode was in the amygdala. In the second week, the tinnitus intensity decreases, but unfortunately in the third week, the tinnitus recurred. And we could not do anything about it, even with reprogramming and the patient. So then I thought, well, we have to use another technique. Instead of going through the brain, why don't we take a classical subtemporal approach and put the electrode underneath the hippocampus so that we can modify this hippocampal activity. But unfortunately, that had no benefit in the patient that we tried, most likely because the electrode was too anteriorly located, and we should have targeted the parahippocampus rather than the hippocampus. Now, so what we found is auditory cortex seems to work in some patients. The amygdala parahippocampal area is, well, the first two were no real success, so we should probably target the parahippocampus more posteriorly. But what about the anterior cingulate? Because the anterior cingulate is where the extralemniscal system partially ends, where patients attach salience or behavioral relevance to their tinnitus sounds. If you can have a tinnitus sound and you say, I don't care anymore, that's what you want to reach. And we know from the 40s that they did cingulotomies, so they basically damaged this part of the brain, and the patient said, well, my tinnitus is equally loud as it has always been, but I don't care anymore. The tinnitus doesn't bother me anymore. So we knew this could be a potentially good target. We studied it initially non-invasively with double coin TMS, where you can target that area that is typically the area of cingulotomies. And then we implanted 2 patients with an electrode on this part of the brain. So basically, they're 2 the same patients, about the same age. Bilateral, this patient bilateral noise, but unilateral noise since an extremely long time, the intensity or loudness was the same for both. The distress was the same. The tinnitus pitch was about the same. The tinnitus loudness was about the same. They were both grade 4 tinnitus, so basically psychologically decompensated tinnitus patients who say, well, if you don't do anything, I'll commit suicide. Even though their HATS, their depression score was not that high, and even their audiometry was similar. So basically, you got two exactly the same phenotype in patients. So we implanted them, and with electrodes on the anterior cingulate and the SMA, and the second patient with electrode on the anterior cingulate and the pregeneral anterior cingulate. And in the first patient, what we saw is that immediately, even with tonic stimulation, the distress improved, the intensity decreased, the loudness decreased, the time of the percentage of the time that the tinnitus is present improved, anxiety, unfortunately we didn't measure, and then we switched them to burst and we got a further improvement. Second patient, which was exactly the same, no benefit whatsoever. Irrespective of what we tried, we had no benefit. And then we thought, well, this is strange because they're the same patients. They should respond both. Or it is similarly to what we had seen to the auditory cortex. Maybe, again, our hypothesis is wrong, and maybe it's the connections that are important. So we did a seed-based analysis from the target where the electrode was implanted, and then a patient who responded had increased connectivity, and a patient who did not respond had decreased connectivity. So basically what this suggests is that if you put an electrode on or in the brain somewhere, and it is not connected to the whole network that generates the tinnitus, then you won't have any effect. Just like if somebody is asleep or under anesthesia in coma, you can give a stimulus, the stimulus will stay local, it won't go anywhere. Whereas if you're awake, the stimulus will spread through the network that is connected to that part of the brain. So there is definitely a future for further studies targeting this area. But maybe we can also treat the attention network, because if you don't pay attention to the tinnitus anymore, then the tinnitus should disappear, just like we don't pay attention to our clothes because it's always the same stimulus. If you can take away the attention, then that might be better as well. So we had a patient who had left-sided pure tone tinnitus, 8,000 hertz, 3 decibel, loud and distressing, and he was a wealthy businessman who was progressively getting worse with whatever we tried. We tried medication, we tried hearing aids, we tried TRT, we tried everything. But irrespective of what we did, he became worse. He tried medication, he tried phase-out therapy, where the idea is that you, just like with the noise-canceling phones that you use on an airplane, that you use something similar. And TMS on the auditory cortex, left and right, did nothing. So we were here with a patient who was very difficult to treat. And then we tried TMS on the ventro to dorsolateral prefrontal cortex, and then the first time we had a real benefit. So we did the same thing, but with neuronavigation, which basically is a navigation system just like you sometimes use in rhinology. And the TMS with navigation clearly showed that we got the best results on the dorsolateral cortex on the right side. So what we did is we implanted electrodes on the dorsolateral prefrontal cortex on the right side, and the first 3 days he was tinnitus-free, but that could just be because of the anesthesia. He had a return to 4 out of 10, which is already better than his 8 out of 10. And then during the year, he progressively decreased in intensity. And here you see the electrodes overlying the dorsolateral prefrontal cortex. Since then, we've implanted a second patient with basically the same results. Now, you can also say, well, what about the C2 nerve, the C2 or the occipital nerve? Because the occipital nerve is at least in the cat, moves the ears towards where the sound comes from, and we know that it is connected in the spinal cord directly to the cochlear nuclei, and if you activate the C2 nerve in animals, you suppress the cochlear nucleus. So basically the idea was, well, if we stimulate there, we can indirectly suppress overactivity in the dorsal cochlear nucleus, which was hypothesized to be related to tinnitus based on animal research. So we looked at 240 tinnitus patients, where 197 were non-responders. So whether we put current on with the TENS and the back of the neck didn't do anything, but we had 43 patients who actually improved about the same, about 40 to 50%, and 6 of them were completely, where the tinnitus was completely gone. We implanted all those patients, and the results you can see here, basically most of them improved with the C2 stimulation as well. But then we had another patient, one of our patients, who had auditory cortex stimulation. So he had an electrode on the auditory cortex, and it suppressed his pure tone tinnitus very well. But the noise did not suppress at all with this stimulation. And of course, because the pure tone was gone, for him, the noise became equally bothersome as the pure tone was on beforehand. So then we tried 10 stimulation, and he had the benefit of the 10 stimulation, and we implanted a second electrode in the C2 area, basically which halved the intensity of his noise. He's still not happy because he wants his tinnitus to be completely gone, but the combination of the two, it seemed to be in this first patient more successful than the individual one. So basically, what we try to do is, based on imaging and non-invasive stimulation, then see if we can modulate the tinnitus percept. The problem with non-invasive stimulation, such as TDCS or TRNS or TACS or TMS, doesn't matter what you use, is that the effect is always short-lasting for about maximum 1 to 2 weeks, and then the effect wears off. So you can't have patients come for 2 weeks, be good for 2 weeks, and then have to come back. So the second step then is to offer a more permanent treatment, which could be an implant. And as for now, there have been electrodes implanted on the auditory cortex, dorsolateral prefrontal cortex, inside the auditory cortex as well, and the hippocampus and amygdala, and the dorsolateral prefrontal cortex. And there is currently a study in the US going with caudate and VIM stimulation based on a case report where a physician actually had tinnitus for a long time, developed a stroke in his caudate, and the tinnitus was gone. So now that is being used as a target as well. And then, of course, the C2 stimulation, or C2 combined with auditory cortex. So in conclusion, tinnitus is common. And for most of the patients, it's not a problem. For 80% of the patients, they can perfectly well live with it. But for 20%, it's a severe problem, going up to suicide. Before I moved to New Zealand, I had a tinnitus clinic in Antwerp, and the suicide rate on 6 years was 7 patients. So about one of those patients committed suicide with a written letter stating that they committed suicide because of their tinnitus, which is very high. You can hardly find that in psychiatric hospitals who are specialized in depression. So it can be a very severe problem. Non-pulsatile tinnitus seems to be related to at least 2 subgroups. The one with hearing loss, which is related to an auditory memory problem, predominantly focusing on a network that is linked to the parahippocampal or hippocampal area, and one without hearing loss, where the compensation mechanisms are failing, but they are compensation mechanisms that are occurring in the auditory cortex. For treatment, we try to treat a cause if we find a possible cause. If that doesn't work, we treat conservatively. And if that doesn't work, we will treat them with neuromodulation, first non-invasively, which we hope will be predictive to tell whether in the longer run an implant will be successful. And so you could say that implanting electrodes in the brain of a tinnitus patient is overdone, but some of those patients are really terribly handicapped, and when they have, for example, both extremely severe phantom limb pain and severe tinnitus, all of them uniformly say that the tinnitus is worse than their worst pain. So I thank you for your attention. Are there any questions?
You can definitely ask questions.
Here. No, looks.
Experience of intrathylacine injection. And also, what is the role of the TM joint pathology in these cases of tinnitus?
Yeah. So the first question, is related to intravenous xylocaine or lidocaine, We haven't used that in our practice because the effect is short-lasting, and it was unpractical to run this in a. So I have no personal experience with it. The second question is collaboration. Well, all of the studies. So every patient that would come to the tinnitus clinic would be seen by an audiologist, by an ENT surgeon, and only if they could not find a treatable cause from their point of view and they could not benefit the patients, they were referred to the neurosurgical unit or the neuromodulation unit. If we saw a patient, if the patient came directly to us, we would first refer them to audiology ENT to make sure that simply removing wax out of an ear would not solve their problem, that we would not go ahead and do invasive stuff if the problem was something simple that could be solved in a very simple way. So yeah, all of this work is basically multidisciplinary.
Biochemical investigation like thyroid function, cholesterol level, and things like that.
Sorry?
If a patient with tinnitus comes to you, what biochemical investigations will you do?
The clinical investigations that we do, and I will talk to that about tomorrow morning in the workshop. So we first start by, well, first they go to audiology and ENT. We characterize their tinnitus, both loudness and frequency. We characterize their distress by one of the many validated questionnaires. That's to characterize their tinnitus. Then we characterize their auditory function in general by audiometry, speech audiometry, ABR, autoacoustic emissions. And then we try to exclude a cause by doing an MRI scan or a CT scan, depending on what is available. And last but not least, we actually also try to, with functional imaging, and that is both EEG and often fMRI, we try to see where in the brain there is abnormal activity, which we could then try and target. And these last two mechanisms, we're actually now trying to use to diagnose whether somebody has tinnitus without that the person has said anything. So with the current support vector machines that we're using, with 87% accuracy, we can tell whether somebody, without saying anything, just by recording brain activity, has tinnitus or not. For distress, success rate is a lot lower. We're about 65% accurate. We can say whether the patient has success or not. And the year coming, we're going to try and push the level of accuracy for just diagnosing whether the person has tinnitus or not to higher levels by using different support vector machines. So I hope that within a couple of years, just with a simple EEG, we will be able to tell, well, the patient has tinnitus or not, and second, how loud might the tinnitus be that the patient perceives, which of course then needs to be validated by the clinical tests. But it seems that there is a potential to come up with an objective way of diagnosing tinnitus in the next couple of years.
Have you been able to record the tinnitus?
No. No. Only in pulsatile tinnitus.
Excuse me. With my experience, I have seen 70% of the TMJ syndrome, with all the investigations are normal, and even MRI, everything, the persisting tinnitus when they go to cold breeze, or this one, loud noises, even the mobile, all these things. I have been studying this one for so many years. The TMJ is 70% of these things are TMJ syndrome.
Yeah. Now the TMJ is indeed, the TMJ we will not routinely investigate, but we will investigate the TMJ if the tinnitus worsens either on neck movements, even just on neck movements, or on mouth movements. Then we will specifically, then we will refer them to a TMJ specialist. But we did not do that routinely in all patients, only if we had a hint that it might be involved.
In the last ISO, one eminent speaker was mentioning about the myofascial dysfunction responsible for the tinnitus, and he was advocating needling of the pterygoid muscles.
Yeah. So initially, we all thought that what is called somatosensory tinnitus was a separate group. Now, if you look at tinnitus patients, about 80% can modify their tinnitus somewhat by pressing on certain areas, by moving their neck or their mouth. So calling a subgroup which is present in 80% does not really make sense. So people are moving a little bit away from the idea that somatosensory tinnitus would be something special, because everybody has connections between the dorsal cochlear nucleus and the C2 and the trigeminal nuclei. So probably it's the interaction there that modifies activity that goes either bottom up or bottom down, top down. So I know there is still a couple of diehards who said, yeah, it is a special subgroup, but if it occurs in 80%, I would not call it a subgroup anymore.
He was suggesting alprazolam in incremental dosages. Thank you, sir.
There are no questions, and we would like to conclude this session.
Thank you.
Your session has been very interesting, but we have very much knowledge about the tinnitus and your work is fabulous. Today we are lucky to have your experience on both pulsatile as well as non-pulsatile tinnitus in one session only. Professor, thank you, and again we welcome you to India. Thank you, sir. Thank you so much.
Thank you.
Thank you, Doctor. I request Dr. Satna Sridharan, Assistant Professor, Medical College, Calicut, to hand over the mementos to the chairperson.